All right, welcome, defenders of the detruser. Thanks for being here on a Thursday morning. This is a pre-recorded session because actually I have to run to the hospital here shortly. So I'm going to hopefully be able to change this up. So it still goes out at 6:45 a.m. Mountain Time, 1:45 p.m. Greenwich Time. So thank you all for being here. And as always, a little cup of morning tea wisdom. This one showed me today perpetual optimism is a force multiplier. You all are force multipliers in the spaces that you inhabit and transform. And together, synergistically, we can make a positive change in the BPH BPO care pathway. And so, with that said, let's start. All right, just quick announcement. Just real fast, remember, for those of you who are able to be accessible to traveling to Dallas in February, there's the Society of Benign Prostatic Disease Conference going on. Great resource to meet with so many other defenders in all phases of the BPH BPO care pathway, the pre-treatment phase, the treatment phase, and the post-treatment phase. Playfully, I like to think of the SOBPD as the Society of Bladder Preservation Defenders, because yes, we are defenders of the detruser. Every Thursday, trying to get you content on Thursdays at 6:45 a.m. Mountain Time, 1:45 p.m. Greenwich Time. Remember, we are chief energy officers. We inhabit and transform the spaces that we have control over for our BPH BPO patients. And every day we are trying to help our men, our BPH BPO men, live the best version of their lives, catheter free and chemical free, as we empower them with the education to make the best decision about their prostate care even faster by highlighting what's at stake if the choice is made not to take definitive action about their prostate. And together, we help them face, embrace, and move through their fear, an acronym which stands for Face Everything and Rise. And so, with that, we'll talk about a LinkedIn poll. I'd like to share with you just one perspective, my experience with the IPSS. And then next week, let's dive into some of the articles. A little change from our planned scheduling content, but just because I have to run to the hospital. As always, big thanks to all the folks who are joining the tribe. Thank you for understanding this mission that it is about the bladder. Here highlighted is urology resident all the way from Ethiopia, and that's awesome. I mean, together we are now beginning to educate the next generation of rising stars of urologists who are de-obstructing surgeons, but also preventative interventionalists. And so with that, let's jump in. Remember the power of the triple Ps. Together, our crusade is prioritizing the preservation of bladder health. We are putting an end to the polypharmacy epidemic, and we are preventing late-stage BPH BPO. Because we all know that macroscopically, we have seen it. Trust the truth of trabeculations on your cystoscopies. We have been given our cystoscopic swords to help us understand bladder health baselines for our men, seeing a normal bladder go to trabeculations, to cellules and diverticuli. And we understand that at an ultra microscopic, electron microscopic level, the deterioration and the destruction that happens as we progress from normal to bladder outlet obstruction to detruser underactivity, as highlighted most recently by defender Amanda Chung at last year's AUA 2023 in Chicago. For we know the 5 stages of bladder health is a patient decision-making aid. Mr. Smith, as that prostate grows tighter, initially the things are going to slow down, or benign prostatic obstruction. Stage 2, if you don't take care of that bladder, it'll become overactive, as we know with detruser underactivity. And stage 3, the rebellious child, which will act out without your permission and squeeze, causing you to leak on yourself, which is urge urinary incontinence. And then the heart attack. Just like the heart muscle can all of a sudden have a heart attack, the bladder can also all of a sudden stop working, and you have to rush to the emergency room because you can't pee and you need to place a catheter. And then stage 5 heart failure, which we also know is detruser underactivity, where if you really don't take care of it, the bladder can go into failure, and you would require a catheter for the rest of your life. which no man wants. And highlighted very importantly was the paper Kaplan, Kohler, Kausick in 2020 in the Journal of Urology, which really showed us for the first time, it gave us a visualization of the window of curability. As expected, as men age over time, the flow will slow down. Initially, as expected, the bladder will compensate by rising bladder pressures, reaching a peak at around the age of 62, after which the bladder begins to decompensate. And so it's important that we are able to help our men by deobstructing the right prostate for the right patient at the right time within the window of curability. And that allows us to look at the 4 pillars, the 4 elements of efficiency for a BPH BPO care pathway, which allows for a good health policy, where we find that sweet spot between treatment durability, economic sustainability, honoring a man's vitality, and we're doing things within the window of curability, where we are optimizing the preservation of detrusor function. And as together, we will proceed with shifting the focus from the treatment phase to the pre-treatment phase of the BPH BPO care pathway. And we can do that by recognizing that drugs are temporizing measures, and we now need to focus on bladder health counseling and bladder health baselines and bladder health screening. And we have to do that by understanding what tools we have, what clinometrics we have. Big shout out to our physiotherapists for kind of highlighting that. And today, let's talk about the IPSS and how do we use that to help screen? How do we cast a wide net so that we can capture as many men who need our help within the window of curability? Because we are trying to prevent late-stage BPH BPO that is crashing into the shores of so many countries at this time, specifically stage 3, 4, and 5, urgent incontinence, acute retention, and bladder failure. Together on LinkedIn, we recognize that folks are frustrated and dissatisfied with IPSS. So what do we do next? We are not victims. We are problem solvers. And when we asked what should we do next, 73%, 3 out of 4 folks said, let's create a new and improved IPSS. Well, in order to even start to consider that, let's understand what we do have now. And as the other 27% said, hey, can we just keep it? Well, let's find how it's being used now. Let's get some insights and then decide what might be the best path forward, recognizing that sometimes the answer is in the space in between, a compromise, a modification, an adaptation, an evolution. So let's see if we can find that space together. Recognizing here that the IPSS is a utilized tool. Here is an example from the NHS in the UK. As you all remember, we are focusing on the EAU as being the tip of the spear, the first guidelines that will take the chance to prioritize the preservation of bladder health and make it our prime directive, elevating what has been existing currently, which is just the management of lower urinary tract symptoms. And as we see here, with all these points of questioning, we recognize that there's 2 main categories. There's the voiding scores, incomplete emptying, intermittency, weak stream, and straining, talking about the prostate, as well as the storage subscore, where there's frequency, urgency, and nocturia, talking about the bladder. And as always, the quality of life due to urinary symptoms is asked, ranging from delighted all the way to terrible. It is a global tool. This is a nice paper from 2022. It is now available in 53 languages. I didn't know that. That's awesome. Of which 27 have been statistically or clinically validated for their translations. That means now in the overall, we have access to the IPSS for 2.3 billion men, or 60% of the men in the world. So it's widely available, and it's widely utilized by the academics as well. As we all know, there's been a key acronym, or MCID, or the minimally clinically important difference. And it's being used as a criteria to assess the efficacy of newer deobstructive technologies. And it's based on the IPSS, where subjects who rate themselves as being slightly improved had a mean decrease in their IPSS of 3.1 points. And so that's been used as a criteria to say whether or not a de-obstructing technology has been efficacious. But I would say just make sure you know your own biases, know your own data. And that's really important as we all proceed using this type of clinometric, the IPSS. So transparency for my own biases. I'm an Olympus consultant, Labary consultant. I used the Labary urodynamics machine for 10 years, Teleflex faculty for 4 years. I currently, I use a Eurocuff pressure flow study currently, and I've done some paid talks for them in the past. And currently I'm a solo practice urologist in the desert of New Mexico in the United States. And I recognize those are my biases coming into these. And I just want to show you some of my data and also the data that we see around our country and now around the world. So it's important to understand your community where the IPSS is being utilized. We know that one of the historic studies is the 1993 Olmsted County study in Minnesota, where they looked at over 2,000 people, where you can see as men age from 40 to 70s, we saw a rise in moderate to severe symptoms scores on the IPSS ranging from 13% all the way up to 30%. And not only your location, but also what about where you're asking the questions. In this situation here, it was in North Carolina in primary care offices in 2007, looking at 440 men. In this subset of the population, now we're seeing 42% of the men with moderate to severe lower urinary tract symptoms with an IPSS score of over 7. Of note and of interest, only 1/3 intended to talk to their primary care docs about these symptoms. We need to do a better job of getting it out to the public that there are risks if the choice is made not to do something about their prostate care, their lower urinary tract symptoms, and specifically their bladder health is at risk. We need to understand that how IPSS works around the world has variability. It's been shown in this paper in 1997 by Abrams and Witches, and I apologize for the pronunciation, demonstrated that where you live has a significant impact and is correlated with the prevalence of lower urinary tract symptoms. So knowing where you live, the regional nuances of your country and of your community. And here's an example. If we look at Nigeria in this study from 2013 from Port Harcourt, Nigeria, looking at almost 300 men, 72% of them had moderate to severe LUTs with an IPSS score of over 7. So you can see here the geographic differences from Africa to the Americas, and I'm sure it exists for other places, Australia, Europe, Asia, and so forth. Just a quick digression as we transition to the next phase of this talk. I always have this section here on this day in history. So in 1935, Amelia Earhart had her first successful solo flight from Hawaii to California, which is a more than greater distance than from the United States to Europe. In 1755, Alexander Hamilton had his birthday. And as all we know, he was instrumental in drafting our Constitution, which is being carefully tested and re-examined right now. In 2008, Sir Edmund Hillary died at 88. He was the first, as we know, to summit Mount Everest with Tenzing Norgay. And in 1878, so for just some fun trivia, in New York City, this was the first year where on this day in 1878, milk was delivered for the first time in glass bottles. All right, so moving on from this day in history, understand your technology. Here on this screen, you can see here, this is a young gentleman who had a 6 French bulbar urethral stricture, and just testing my own technology and my own pressure flow studies, nicely showing where the X marks the spot. This is this patient in the obstructed category for pressure flow studies showing bladder outlet obstruction. And so after verifying your technology, begin to understand how your men in your community begin to interact with the IPSS score. For my men in New Mexico, it's a challenge. This is a great example on the left here, a 65-year-old. He's putting here a question mark. He's like, I don't know, straining? Do I strain? And you can see here, he's in between. He's not really sure. And he's making 2 choices for each of the elements of the IPSS, or for most of them here. And so his IPSS could have a 4-point swing everywhere from 13 up to 17. So recognize there's a 4-point swing there, but we looked at the minimally clinically important difference. The MCID was 3 points. So we can see that there's some variability, and that variability could affect how we see whether or not a de-obstructing technology is efficacious. On the right, this is kind of a little bit of a funny story. This is a 23-year-old with a little bit of anxiety, totally normal, peeing great and having no issues in his life. And then he saw one of the BPH BPO advertisements where they had they're spraying the fire hose, and it gave him anxiety. And he's like, oh my goodness, all of a sudden, maybe I have BPH BPO. And so he made it a point to see us at MD4Men. And now he has symptoms of frequency. And a guy who's perfectly normal and perfectly happy with a little bit of anxiety now has a symptom score of 6. So it's just interesting to watch in a 23-year-old healthy man. If you create the concern that they might have a problem, he can begin to have lower urinary tract symptoms. This is an example of a 74-year-old with 137 gram prostate with a history of acute urinary retention, put on medications, and they were like, his physicians were like, hey, you could just be on these medications for a very long time. Interestingly, with all of that going on, his symptom score was only 7, categorizing him as mild in nature, and just seeing the discrepancy between the symptom score and his life on medications with all the side effects of medications, with a history of having to go to the emergency room with spontaneous retention, with a massive prostate. Interestingly, on the quality of life, he was mostly satisfied. We need to do a better job of educating with bladder health counseling about what's at stake, what's going on, because I guarantee you, if his bladder went into stage 5, bladder failure, detrusor underactivity, atonicity, or if he had multiple episodes of retention, he would not be happy. He would be much more than mostly dissatisfied with that type of education. And then on this page, this is a 65-year-old with a history of BPH BPO for 20 years with slow flow, urgency, frequency, nocturia over the last 3 years in retention, who's now being managed on self-cath. And he sought us out because he just wants his data. What's going on? Are there other options? We should not be leaving these men to self-cathing without giving them their data. Let's get pressure flow studies. Let's find out the prostate size, the prostate shape. Let's look at the trabeculations in the bladder. And this guy had a miserable life and needs our help. And we can do that by giving them accurate data, because accurate data drives appropriate decision making. Of note, he's 65, and just highlights it once again. What happens if we had criteria for bladder health screening? If we had screened this guy, I don't know, 50, 55, 60, could we have saved him from a life of being dependent on catheters? Or at least been able to intervene sooner to minimize the risk of late-stage BPH. On this slide here, this is a 53-year-old with a symptom score of 6. I educated him about the 5 stages of bladder health, what's at stake, what's at risk. Interestingly, when we did the pressure flow study, he was obstructed, and he's at 53. Now, I'm not advocating that should be screening started at such young ages at 50, because I think it has a significant impact on the economic sustainability of that type of pathway with that type of screening at such an early age. But we need to think about these things now. And what is that sweet spot with the appropriate amount of screening so we can intervene within the window of curability in a timely fashion that works for our healthcare systems, our practices, our physicians, and so forth. Here's another IPSS, 60-year-old healthcare provider who understands what bladders are. They understand that there are only 2 main organs that cannot be transplanted, the brain and the bladder. And despite all this knowledge, he had decades of lower urinary tract symptoms, and then showed up in the emergency room up in Santa Fe in retention with 2.5 liters in his bladder. He had failed multiple attempts to kind of learn self-cath, and then he actually failed to want to even have a fully catheter placed. And he saw me seeking a second opinion. His post-void residual was 881 cc's, and he was in complete denial that he had a problem. And his IPSS score was only 7. And this slide here, I think it's really important to recognize that we need to be within our clinics, within your practice, within the operations that you can control. Make sure that we're asking about these symptoms of the prostate and the bladder, the lower urinary tract symptoms for all men. And depending on where you are in the world, perhaps starting at the age of 45 or 50. Here, these are men on the left here. A 55-year-old came in for low T and erectile dysfunction. His IPSS was 20. On the right side, there's a 53-year-old gentleman who came in for Peyronie's disease. His IPSS was 12. And I'm glad that he came in because we then went on with pressure flow studies and he was obstructed on pressure flow. Here highlights slides on we need to do a job of better education for our fellow physicians. This is a gentleman here with an IPSS of 14 put on medications, and the patient came in saying, look, my doctor who graduated from Harvard says I'm fine. So actually, I'm not sure why I kept this appointment. And what we had to do is educate him. Hey, you are not necessarily fine. Let's get the data. Let's put the cards on the table. Let's see what's going on with your bladder so that we can figure out, is your bladder fine? And on the right, a 65-year-old who was told by 2 urologists that he was totally fine. He was okay. He was on multiple medications with an IPSS of 21. And he was mostly dissatisfied. And he was seeking a third opinion because he did not want to continue this life. And he did not want to be a victim of the polypharmacy epidemic, having to continue to live the next 15, 20 years of his life with the side effect profile of medications. And we said, hey, let's just talk. Let's figure out what's going on. Let's get the data on the table. Prostate size, prostate shape, detrusor function. Let's figure out a path forward together. And on this slide, once again, looking at the IPSS in my community, and you should be doing the same in your community. This is a 74-year-old, a Vietnam War vet. He was actually a Top Gun pilot, coming in with an IPSS of only 3. But listening to him and knowing who he is, I was like, you're getting up 3 times a night. Let's at least just let's figure out what's going on, because we don't want to let your bladder go into stage 3 urge incontinence, stage 4 an episode of acute urinary retention, or stage 5, heaven forbid, your bladder begins to fail and begins to die. And on pressure flow studies, he was obstructed with bladder outlet obstruction and needs us to intervene as what we do as defenders of the detrusor at the right time within his window of curability. And so what I hope to have highlighted today, we often hear the term that we should not bear false witness. The truth is, our men, our BPH BPO patients, are bearing false witness against their own bladders. This is false testimony. As we define false testimony, is knowingly stating as fact that which is untrue, to begin or perpetuate a rumor by lying about a person, a thing, or event, or one's own bladder. So please, we need to let our men know they need to love their bladders as themselves, because in truth, our patients are bearing false witness to their own bladders. And this is a paper from Ashim and Abrams in 2006, where they asked, is the bladder a reliable witness for a different urodynamic diagnosis of detrusor overactivity? But I would say on top of this is that the bladder is a reliable witness for bladder outlet obstruction for BPO when we allow it to speak. And the only way we can allow it to have its voice heard is by doing testing, by getting bladder health baselines, by getting cystoscopy. So look for trabeculations, cellules, diverticuli, and getting pressure flow studies when available to understand the detrusor function and where they are in the 5 stages of bladder health. So with that, remember, this is where we're trying to go. We are the 3 Ps: preserving bladder health, preventing late-stage BPH and BPO, putting an end to the polypharmacy epidemic. And we do need to get our guys who are at risk, bladder health counseling, bladder health baselines. And now we need to figure out, how do we cast an appropriately wide net to capture the men who need us the most, so that we can intervene not only as de-obstructing surgeons, but as well as preventative interventionalists. And I'm just beginning to form that with your help. Together, collectively, we are drafting the ManVsProstate Manifesto, the ManVsProstate Monograph, looking at, hey, is it indicative that if a guy has a single episode of urgent incontinence or acute spontaneous retention, that they should be funneled into bladder health counseling and bladder health baseline? Is it such that with an IPSS over 7, moderate to severe, we recognize that that may be casting too wide a net, so we need to increase the criteria or the stringency by which we refer, and say that not only do they need to have moderate to severe symptoms, but in addition, they should either have a Qmax on uroflowmetry less than 15 or a PVR over 100. And then we also need to talk about at what age, and we need the research to support, at what age should we be doing preventative screening for bladder health, so that now using cystoscopy and pressure flow studies, let's get the qualitative and the quantitative data to assess the detrusor function, so that we can risk stratify bladders out there for how at risk are they for death and dysfunction, so that we know when is the right time to de-obstruct within the window of curability, when it is warranted. And so with that, thank you all for being defenders of the detrusor. Let's go save more bladders. And let's end with a quick health quote, an Arabian proverb: he who has health has hope, and he who has hope has everything. And so with that, thank you so much. We'll be back next week. I'm going to try and figure out how to now connect this to LinkedIn as a pre-recorded video, since I won't be able to actually make it at the live stream time, since I have to run to the hospital. So sending positive thoughts for you all for a great week and a great weekend, and we'll see you next week. All right, have a great one. Take care now. Bye.